Awards. Rules for this paper is 8 minutes for the participant and 2 minutes for question answer session. Question answer session will be, questions will be asked only by the judge. Now may I invite respected chairperson ma'am, Dr. Pillu Hakim ma'am, and judge for this session will be Dr. Dhananjay Kulkarni. So our first participant is Dr. Sanika Kalaskar.
Hello, good morning. We are starting with RAF Cooper Award papers. For this session, I call over Dr. Shashikant Masha to be a chairperson and Dr. Dhananjay Kulkarni and Pillu Hakim ma'am as judges of the session. The session will be, the participant is supposed to have his presentation for 8 minutes and judges will ask questions for 2 minutes. The bell will ring after 7 minutes and after 8 minutes everything will be blackout. So your presentation will not be even seen and only judges are allowed to ask questions. Okay? So I'll give the mic to Pillu Hakim ma'am. She wants to just tell something about the RAF Cooper Award.
I'd just like to say a few words because Dr. R.A.F. Cooper was my father, and he was one of the pioneers in ENT in India, having started and being a founder member of the AOI as well. He then became professor at the Grand Medical College and remained so as head of department. His main aim was to encourage youngsters, and whenever anyone graduated, he always would often offer his own clinic for them to start their career. And he was very keen that young people should come up and should be taught. So I'd just like to say, and that is one of the reasons we started this session, so that youngsters could be encouraged to do well. Thank you.
Thank you, ma'am. Over to the first presenter.
Good morning to all the judges and the delegates. My name is Dr. Sanika Kalaskar, and the topic for my paper presentation today is Study with Autologous PRF and Type 1 Tympanoplasties. Use of platelet-rich fibrin was first described by Dr. Joseph Chukron in 2001. It was used in oral and maxillofacial surgeries to improve bone healing and implant dentistry. Since then, its use has been on a rise in different specialties. Platelet-rich fibrin is a second-generation platelet concentrate that is prepared without the use of anticoagulants. PRF is formed mainly of platelets, leukocytes, which are trapped within a fibrin matrix, forming a mesh together with growth factors. PRF fulfills all three essential requirements of tissue regeneration, which are, it serves as a three-dimensional fibrin scaffold, it contains autologous cells like neutrophils, leukocytes, platelets, and macrophages. It acts as a reservoir for natural growth factors, which are released over a period of 10 to 14 days. The aim of my study was to assess the impact of topical use of autologous PRF on tympanoplasty outcomes in terms of graft healing and hearing outcome. My study was a prospective comparative study of 60 patients done over a period of 4 months with inactive mucosal perforations who underwent type 1 tympanoplasties, which were randomly divided into 2 groups. Group A contained 30 patients who underwent tympanoplasties using temporalis fascia graft with autologous PRF, while Group B had 30 patients who underwent tympanoplasties only using temporalis fascia graft. And all the patients were assessed clinically to evaluate healing of tympanic membrane, the audiometry, and any side effects. In our study, we included all the patients of inactive mucosal CSOM, pure conductive hearing loss, patients with dry ear for a period of 4 to 6 weeks, and patients between the age of 15 to 60 years. While the patients with active mucosal CSOM, sensory neural hearing loss, history of previous ear surgeries, comorbidities such as diabetes, hypertension, etc., and age less than 15 or more than 60 years were excluded. This is a video showing primary steps of preparation of PRF. 10 ml of blood was drawn from the patient and was immediately transferred into sterile tubes which were without anticoagulants and placed into the centrifuge and set at the rate of 3,000 rotations per minute. At the end of 20 minutes, we got the PRF. So this PRF is the material, jelly-like material, which is present in the middle, which contains platelets in the fibrin mesh along with leukocytes and growth factors. The supernatant was platelet-poor plasma, and RBC clot was formed at the base. This is a small video. It is showing the fibrin clot which was obtained was then removed from the tube and then compressed between two sterile glass slides to form a fibrin membrane, which was then cut into thin strips. This is an intraoperative video taken after the placement of temporalis fascia graft in the tympanoplasty surgery, after which thin fibrin strips were then placed over the fascia graft assembly. This is the picture of tympanic membranes at 3 weeks post-op. And these are the pictures of neotympanoma 3 months post-op. As we can see, there is an evident improvement of hearing with the PRF use at the end of 3 months. The increasing use of PRF has been because of the easy accessibility, cost efficiency, abundant availability, ease of preparation and handling. Since it's easily moldable, leukocytes in the PRF act bactericidal and prevent infections, and there are no side effects noted whatsoever. The results of my study were that the age of the patients varied from 15 to 60 years, and 60% of which were females. Less than 10 decibel airborne gap was obtained at 3 months post-op, in 43% cases with PRF use and 16.6% cases without PRF use. The overall graft uptake was observed in 96.6% in tympanoplasties with PRF and 73.3% in tympanoplasties without PRF. The difference between the post-operative graft success of tympanoplasties in which PRF was used and those in which PRF was not used is statistically significant, and the success of the graft was not dependent on the size of perforation, and there were no side effects noticed in the follow-up period. Hence, to conclude, I would like to say that the autologous PRF enhances healing process of the graft and resulted in improvement in hearing without any side effects, and so PRF should be a preferred material along with fascia graft. Thank you.
Sanika, lovely presentation.
Thank you, sir.
And it's a nice way of thinking also, because these days PRP has been used in many surgeries. The age group you said was 15 to 60.
15 to.
So when you say age group of 15 to 60, that means there are a lot of comorbid conditions also which you have not talked about. Because when you have a group and you are comparing, then you've got to talk about the comorbidities also. Suppose like a patient was a diabetic patient and a hypertensive patient, any renal issues. So all these things also matter in healing, which also should have been added in. This is what I think.
Okay.
Or have you thought of and not put into this?
Sorry, sir, I did not get it.
Or these points were thought of and not...
Yes, sir. So we specifically preferred patients who were not diabetic or did not have any comorbidities, who were healthy, and we explained to them that it would affect the graft healing, and so we selectively chose patients who were without comorbidities for the whole study.
In subtotal perforations, or you didn't try it, where there's only a rim?
Ma'am, we mostly had large perforations who significantly had like a little more rim than the subtotal perforations. We did not try and...
Right.
Any experience in ossiculoplasties for this fibrillary globe?
So we have tried using it, but we did not do a study over it. So similar in the ossiculoplasty, like we use the cartilage, so we can use PRF additionally as we have shown, which will definitely improve the graft healing and uptake.
Thank you.
Thank you so much.
May I call upon the second speaker, Dr. Madhuri More?
Good morning, everyone. Myself, Dr. Madhuri More. I'm working as an assistant professor in VDGMC Latur. My today's topic for paper presentation is Unusual Foreign Body Impacted in Esophagus, a case series. Foreign body ingestion is an everyday occurrence and a common emergency presentation. Foreign body ingestion accounts for about 4% of all emergency endoscopies. Accidental or intentional ingestion of foreign body is a frequent event, especially in children. Coins comprise about 70% of all foreign bodies, followed by batteries, toys, food bowlers, jewelry, and danger. The esophagus is the most common site of impact. Lodgement of foreign body occurs more frequently in the cervical esophagus, that is 57%, compared with thoracic esophagus 26%, or distal esophagus. And the risk of foreign body infection is greater in the presence of structural or functional esophageal abnormalities. Esophagus is a fibromuscular tube about 25 cm long in an adult. It extends from the lower end of pharynx to cardiac end of stomach, that is C6 to T11. It runs vertically but inclines to the left from its origin to thoracic inlet and again from T7 to esophageal opening in the diaphragm. The four demonstrable constrictions from the above downward are at cricopharyngeal fold, the crossing of aorta, the crossing of left bronchus, and the hiatus esophagus, as shown in the figure. Common foreign body in esophagus, these are metallic and non-metallic. Metallic are coins, pins, safety pins, buttons, button batteries, piece of metal object, blades and broken spoons. Non-metallic are glass beads, marbles, plastic toys, piece of plastic objects, impacted food bowlers, pencil piece. Clinical presentation, there are no absolute diagnostic symptoms, but sometimes following symptoms may be present: dysphagia, pain, drooling, irritability, subjective sensation of foreign body, dyspnea, cough. There are no constant physical signs associated with uncomplicated impaction of foreign body in the esophagus. Now, etiology, the lodgement of foreign bodies in the esophagus is influenced by the shape of the foreign body. Second is resilience of the object. Third one is the size of foreign body. Fourth one is narrowing of the esophagus, spasmodic or organic, normal or pathologic. Paralysis of the normal esophageal propulsory mechanism. Site of lodgement, almost all foreign bodies are arrested in the cervical esophagus at the level of superior aperture of the thorax. A physiological narrowing is present at this level, produced in the part by muscular contraction, mainly by the crowding of adjacent viscera into the fixed and narrow upper thoracic aperture. If dislodged from this position, the foreign body usually passes downward to be arrested at the next narrowing or pass to the stomach. The narrowing at the upper thoracic aperture arrests it because the esophageal peristatic musculature is feeble as compared to the powerful inferior constrictor. Now the treatment, it is a mistake to try to force a foreign body into the stomach with a stomach tube or bougie. Esophagoscopy should not be done without a previous X-ray of the chest and esophagus except for urgent reasons. Blind instrumentation is dangerous and in view of safety and success, esophagoscopy is reprehensible. Now this is a esophagoscopy set having esophagus, having tube handle, the suction tube, operating microscope, fiber optic cable and camera. These are the different esophagoscope we can use, adult and children. Now these are the different esophageal forceps having crocodile jaw, duck jaw, round jaw left bend, round jaw right bend, esophageal forceps with tightly grasping head, esophageal forceps with straight head. Now direction of the esophagus enters the chest in a decidedly backward as well as downward direction, parallel to the trachea, following the curves of cervical and upper dorsal spine. This is the positioning of the patient. Patient lying supine with extension of head and neck. Surgeon stand at the head of the table. Introduction of the esophagoscope may be divided into 4 stages. Entering the right piriform sinus, passing the cricopharyngeus, passing through the thoracic esophagus, passing through the hiatus. Now how to hold the esophagus is steadied by the left hand like a billiard cue. A terminal phalanges of the left middle and ring fingers hooked over the upper tip. While the left index finger and the thumb encircle the tube, retract the upper lip to prevent it being pinched between the tube and upper tip. The right hand holds the tube in a pen fashion at the collar of the handle, not by the handle. Indications, esophagoscopy is demanded in every case in which a foreign body is known to be suspected of being in the esophagus. Contraindication, there is no absolute contraindication to careful esophagoscopy. Now these are the cases. Case 1 is a 3-year-old male child was brought by parents to our casualty with a history of accidental ingestion of earring. Informant was mother. Complaints of irritability, dysphagia, excessive crying was there. On X-ray we could detect a earring in esophagus at C4, C5 and C6 level. Case 2, a 5-year-old male child was brought by parents to our casualty with a history of accidental ingestion of metallic ring of toy car. Informant was mother with complaints of foreign body sensation and dysphagia. On X-ray, we could detect a metallic ring in esophagus at T1, T2 level. Case 3, a 9-month-old child was brought by parents to our casualty with a history of accidental ingestion of silver anklet piece. Informant mother with complaints of irritability, inability to feed, excessive crying. On X-ray, we could detect a silver anklet piece in esophagus at C5, C6, C7 level. Case 4, a 35-year-old female was brought by relatives to our casualty with history of accidental ingestion of chicken bone with complaints of foreign body sensation and dysphagia. On X-ray, we could detect a radiopaque foreign body in esophagus at C4, C5 level. A test CT scan done and confirmed the same. In all above 4 cases, we did emergency rigid esophagoscopy under general anesthesia using forceps foreign body removed with utmost care. Check esophagoscopy was done with evidence of active bleeding or perforation. The patient was kept in ward for 24 hours observation and was discharged with oral analgesics. Post-operative recovery was uneventful. Overcoming difficulties, choosing right size of esophagoscope, positioning of unusual foreign body must be oriented with perioperative X-ray and the sharp side should be rotated or released from esophageal mucosa inside to overcome the esophageal perforation or any trauma to the esophageal mucosa. Take-home message I want to give is emergency cases with sound minds leads to lesser complications. Never insert esophagoscope with pressure. Special care should be taken around the cricopharynx. Gentle dilatory pressure with the beak of esophagoscope should be maintained until cricopharyngeal relaxation achieved. Don't forget to do check esophagoscopy at the end of the procedure. Thank you.
In what way do you feel that these foreign bodies were unusual?
Because we had an occurrence of coins only at our institute. So I found these things after my 4 years of experience in my institute, I had only coins. After that, this foreign body I faced and the difficulties, whatever I encountered. So I thought of presenting in front of you.
And did any of this type of foreign body occur in the trachea? Did you find any in the respiratory tract? Or all of them were in the esophagus only?
All of them were in the esophagus only.
But have you ever found in the respiratory tract?
No, ma'am. I only had a coconut and groundnut pieces in the trachea only we had at our institute. Oh. This kind of foreign body we didn't face till date.
No, the reason I asked you was that once we had actually a ring of that a person had. It was there for 2 years in the trachea.
Okay.
And because it was round, the patient was breathing through it. So that's why I asked you the question.
Dr. Madhuri, lovely presentation.
Thank you so much.
And as ma'am said, yes, we thought we were expecting some unusual case or any unusual into it. But yes. Anyway, apart from that, you should mention, I think, there should be a mention of time from the ingestion to the removal. So yes. That makes it more easier to understand, is the foreign body locked for more of a period of time, how difficult it would have been yes. to be removed. So that was I think that would have been.
Yes, sir, definitely. Yes. Thank you, sir.
Thank you.
Our next speaker is Dr. Neeleshkumar Pandit.
So good morning everyone. I am Nilesh Pandit. I am representing IIT Bombay. And we have done some research on tinnitus. So I would like to present this, our research on tinnitus. So my project title is One-Stop Solution for Precise Tinnitus Matching and its Management. So we are offering the complete solution which includes the diagnosis and treatment also. So we define as listening is a joyful gift of nature. When joyful gift become a painful condition is called as a tinnitus. And the problem is worth solving because this problem is faced by doctor as well as for the patient. So precise diagnosis and management is tinnitus pose significant challenges to ENT and audiologist. And for patient, quality of life and work efficiency is negatively impacted in the tinnitus patient. So is the tinnitus is really a concern? So answer is yes. Because if you see the global numbers, it's around 740 million adults globally affected with tinnitus, and pursued around 120 million people pursued a major problem. Around 16% patient needs medical attention, and this is all are the recent data. Around 6.7% patients in Indian population we can find between the 18 to 60-year-olds suffering with the tinnitus. So what are the current approaches? The current approaches, when we talk about the diagnosis, we use a audiometer for a tinnitus matching, but it has its own limitations. That precise tinnitus sound matching is not possible with audiometer. Pitch range is up to 8,000 only. Pitch resolution is at only octave range, and loudness resolution is 5 dB HL. While when we talk about the maskers, they have the first social stigma, offering single therapy only. Risk of ear deafness and cost is, of course, varies from 40,000 to 1.2 lakhs. So challenges faced by the medical profession, basically there is no precise tinnitus diagnosis device was available. Conventional treatment has a social stigma, risk of ear deafness, and not a pocket friendly to the patient. There is no FDA drug is available for tinnitus, and no integrated platform available that offer the precise diagnosis and customized management. So current approach makes tinnitus management challenging. Moreover, the outcomes are unsatisfactory. So we at IIT Bombay are argumenting the successful outcome in tinnitus with a precise diagnosis and its customized management. So what is our project? So we have developed a device which helps for the precise diagnosis, or we can say precise matching of tinnitus. This is very, very small device. The precision is more than a year capacity. The weight of this device is just 350 gram and ease of operation. In terms of number, it is more 200 times precise than audiometer. Pitch range is also 65% more than audiometer. Loudness resolution 5-fold more than audiometer. When we talk about a software, so this is a software we develop for the patient. This offers a management, and this offers a multimodal management. It is not a single therapy. Also offers a disease progress tracking. It's secure and user friendly. There is no social stigma associated with tinnitus, since the masking and TRT is given with the headphones. The most important thing that this project is connected with the IoT, so we can track the patient's activity and also track the tinnitus improvement also. So this is what the report we get on the regular basis. So this is what crisp about my project. So when we talk about the resolution, the tinnitus matching resolution is at a 20 hertz resolution in the pitch, and loudness is a 1 dB SPL. Frequency range is up to 13 kilohertz. Amplitude is up to 100 dB SPL. It takes not more than 5 to 7 minutes for a tinnitus matching. If we talk about the TME solution as a software, so it's offered a lot of therapies. We can talk about that masking therapy, attention divergent techniques, cognitive behavior therapy, tinnitus retraining therapy, experts counseling, and all are customized. It's provided as per the patient's requirement. Software can be used offline. Customized secure software is strictly under the guidance of doctors and audiologists. That means without doctor's permission, patient cannot use the software. So we conducted a clinical trial also. The effectiveness of precise tinnitus matching and IoT-based personalized multimodal management in the tinnitus patient in India. We have conducted this trial at Hinduja Hospital under the observation of Dr. Malignant and his team. The objective of study is to evaluate the efficacy of the precise tinnitus matching device and safety and efficacy of tinnitus management software. The methodology what we have used, we selected a patient age between 18 to 65, idiopathic moderate to severe tinnitus patient or Meniere's disease, predominant tinnitus symptoms, and patient who had a tinnitus with the moderate to severe SN loss hearing. The study period was 8 weeks. And this is what the result. We have evaluated patients on the 3 different scales. One is on TFI, tinnitus functional scale. So you can see from the day 0 to day 60, this is how the patients are improving. On the NRS scale also, there is a NRS scale, we can see that there is an improvement in all scales. We evaluated patient on tinnitus handicap inventory also, and we evaluated the tinnitus severity scores also. So in all 3 scales, we found that there is an improvement in the tinnitus, especially in the quality of life of patient. This clinical trial is getting published on 21st of December this month. Online, will be available online. So conclusion and way forward, the management of tinnitus continue to pose a challenge to a clinician. The new tinnitus matching device is a unique non-invasive device, offers the precise tinnitus matching. The tinnitus management software allows patient to treat with the customized multimodal modalities, which include the masking therapy, TRT, attention divergent techniques, CBT. And multi-center trial is in a larger population is recommended, which we are starting very soon. Uh, a wholehearted thanks to funding agency. We got a funding from Tata Trust and Vadhwani Group. Medical panel, Dr. Milind Ketan and his team was there, and technical support from the IIT Bombay. So thanks a lot to everyone, and I'll be happy to give some answers if you have questions.
Dr. Nilesh, lovely thought, because one of the topics which is really very neglected. So, but I just want to know, you use the routine headphones attached to your mobile, because you had shown that picture that these days those phones are
But
used.
these headphones are calibrated. It is not a regular headphones.
Agreed. So you mean for how long duration during the day they are supposed to use the headphones?
So in the clinical trial, we recommended patients to use the masking and TRT for 15 to 20 minutes in the morning and 15 to 20 minutes before going to sleep. And the attention diversion technique, they can use as per their own convenience. We have given a timeline or time limit to each activities. So the time limit is maximum 60 minutes per day. So patient cannot use more than that.
What is the main reason for that?
Sorry?
Because of damaging the ear further?
No, generally what happened that habituation should not be there because this is the activity. In the attention diversion, we have kept some different mind games also. So patient should not be habituated with using the headphones, using the mobile phone. So we have given the restriction. And also when we given a restriction of timeline, so we can give the quantitatively, because in terms of drugs, we always give some fixed dose. Similarly, in case of this software, we have given a fixed timing to all the patients.
And how long are they recommended to use it?
So basically, this is safe to use, but we found that patients are improving, and generally 3 to 6 months is more than enough to stabilize the patient, because we found that the hearing loudness of tinnitus is improved, and patient is not complaining tinnitus. So after 6 months, probably the patient did not to use.
Right. Okay.
Is it similar to the sounds created by the tinnitus maskers, or it is something
No,
different?
it's not a masker, because tinnitus maskers offer only white noise.
Yeah.
We develop a different types of noises, which is very soft, which includes a red, pink, and there are different patterns. So we have more than 150 different types of maskers and TRT therapies, and that's offer the customization to the patients. And this customization is basically the loudness and frequency what we have identified from the device, and the other customization is based on the THI scores what we have taken from the day 0. So these two things we generally integrated in the software, and the software offers a customized therapy to each patient.
Very well thought of and very nicely done. Thank you,
sir.
Do you customize it yourselves?
No, it's a software. So we have coded the software in such a way that automatically that the patient will get the customized correct one. Okay. And these all are controlled by the doctors. So we have developed the system, but all the authorities, or we can the prescription rights given to the ENT doctors only. So unless and until they recommend, patient cannot use this software.
Right. Thank you.
Thank you.
May I call upon next speaker, Dr. Sapna Parab?
Good morning, everyone, respected judges and chairpersons and my dear friends. Today I am going to speak upon our developed product that is known as the portable goose neck system as a third arm for holding endoscope in two-handed endoscopic ENT surgery. I'm Dr. Sapna Parab. I work in Talegaon. So in this video, you can see the goose with which it moves its neck, the flexibility to fetch the grains, what it is looking out for. Look at the flexibility, the pliability, and the directed movements. So similar to this, we want to incorporate the motions of the human hands, that is flexion, extension, radial rotation, as well as the ulnar rotation. So whenever you want to work with an endoscope holder, it should have all the parts and all the functions of your human hand so that you can direct to any specific part of the ear, nose, or throat cavity. So this was all what was thought when we thought of developing an endoscope holder, which is based on the goose neck. So we all know why endoscope for ENT surgeries. All know that it gives better vision, optics, panoramic view, precision of the dissection tissue, as well as magnification, and it's an excellent teaching aid. So the aim of my study was to present the feasibility and usability assessment of our portable endoscope holder, which is based on the goose neck system. and it's a retrospective, non-randomized clinical study. We have included the patients what we operated from January 2022 to November 2023, and it involved total of 652 surgeries which were done with the help of the endoscope holder. That is all the ENT surgeries, not only the ear. So this you can see on the right hand side, the picture is how it looked, the designs on the paper, and the left hand side is how it is in the theater. So from paper to the theater. So what is gooseneck and why? So we all have used gooseneck basically for our different functions. See the portability, the TV also which is there, it may be mounted, even your mobile holder. So just using this gooseneck for the endoscopic ENT surgery, I won't go into the technical details of it, what a gooseneck is, but definitely what I would stress upon is the pliability, the functionality, and it will remain in that position. It should have that endurance, that strength, not only to maintain the weight of the endoscope, the camera, as well as the whole system. So that the main thing is when you're doing endoscopic ENT surgeries, you're very much nearer to the structures. It should not droop down and damage the system or damage the organ what you're doing into. So you can see over here, the gooseneck is the third part of the endoscope holder. Basically, it is having the part which is connected to the OT table. The second one is the connection between the first and the gooseneck, and then the gooseneck is attached to the rack and pinion, which forms the main part of it. Basically, rack and pinion is nothing but, we must have all seen in our histology slides, we move it with a horizontal bar which gives 1 millimeter precision movement. So similarly over here, we use it for the vertical downward movements into the cavity. It may be the nasal cavity, the ear cavity, or the tonsils, what you're operating for. And the most important thing over here, what you can see is the slot to hold the endoscope. And then you can mount your respective camera, what you're using. So this is typical how it looks in the two-handed endoscopic ENT surgeries where your both hands are free for the ear surgery. And this is the operative setup which we use along with our other instruments, what we have developed for endoscopic ear surgeries. So basically the motion, what you can see over here, so just like your ulnar rotation, the radial rotation, it moves totally, like it's not a fixed. So when I say it's a dynamic holder, it is performing all the functions of your hand. It's not a static one. So all the movements, once you place the endoscope, so all these movements are imparted to the endoscope once you attach the endoscope to the slot over there. So the position, so when we do the ear surgeries, the endoscope holder is mounted on the other side, the contralateral side, to which the patient's ear is operated. And in the case of nose and the throat surgeries, it is always attached onto the left hand side of the operation theatre table. So the results, overall practicality of using this device was evaluated along with its beneficial aspects, that is ease of usage, handling, fixing, as well as the ergonomics. Applications, it is used for multiple things like tonsillectomy as well as for septoplasty, open rhinoplasty, oral surgeries, as well as for certain ear procedures. We do not advocate it for all the ear procedures, for which we have developed another endoscope holders. So this is how you can see the pictures in which the ear, the endoscope holder is used for nasal surgeries. And you can see the beauty is, if you see something, you'll be able to teach it better, it will be replicated well, and it can be precisely demonstrated. Also the pathology can be seen, you can give better results to the patient. These are the sequential photos in rhinoplasty. This is the video what we have seen in which I'm using the goose neck, which is mounted, as you can see, on the other side. I'm on the right hand side. The endoscope holder is being mounted with the endoscope, and in this we are using the striker camera. So basically this shows the ergonomics and the position and the comfort, because you're looking at the on the monitor. So it has already been published. So this is endoscopic tonsillectomy procedure with the gauze neck, which has been published in the European archives. This is the video which you can see. So basically when I say endoscope and endoscope holder, it's beautiful because we have not seen a tonsil like this during our UG days. And the beauty is, if the student can see it, there will be no complications, there will be not much of primary hemorrhage, secondary hemorrhage whatsoever. So basically, finally, precision, learning, as well as the better delivery of the results and overall better to the society. So applicability of uses, this is all the procedures what we have done with the thing, and this is the score, the average score, so maximum out of 5. So 1 is the least and more than 4 or 5 is the best ones. So this is a proof concept study. This is the first one study which we have published with this endoscope holder, and the highest feedback shows that it's basically having good ergonomics results. Limitations is basically any new instrument when it is incorporated into any system, you have to train, learning curve is there, patience is required because you are handling something which is new, training and also the fogging, you have to take care of the instrument as well as the other structures. So final thought, it's a good option for two-handed endoscopic ear surgeries without drilling, with drilling, and definitely it will require training and we have to incorporate all these into a curriculum rather. Thank you so much.
Thank you. It really was an excellent presentation.
Thank you.
And the whole concept was good.
Thank you.
May I ask who really started it? Who had the initial thought?
Ma'am, myself, Dr. Khan and myself, we are a team, we work in Talegaon. So this is a fourth endoscope holder what you have developed. The first one is an attachment to an already existing microscope, so that we had developed in the year 2013. So that has been patented by the Indian Patent Act. Then another one was the floor model in which we incorporated the actions. Third one was the EndoHold GS based on the gas spring action which has received the US patent, and this is the fourth one. So this we are mainly used for the nasal and the throat surgeries because of its basic thing is it can stay in any position. It is based on the action of that it is pliable, flexible, as well as it will be remaining in the same position. Basically over here the quality matters. So the part of the gooseneck is the main part. Out of the other parts which are there, the horizontal part which is attached to the table. So this is the main part. So we are a team of 2 people. The main boss is Dr. Khan who has developed it, and we are into endoscopic ENT surgeries, ma'am.
Right.
Yeah, thank you.
Lovely presentation.
Thank you, sir.
And we've seen your innovations over a decade, more than a decade, I would say. Just one question.
Yes, sir.
As this being a pliable one,
Yes, sir.
over a period, do you think it might start sagging down or its tensile strength may go down?
Yes, it's a very good question. So what I said just now is the quality matters. So for this gooseneck, we are importing the US one, sir. And what I have not told in the technical details, gooseneck is nothing but it's a series and sequence of concentric circles or rings which are placed in position. So the internal angle and the external angle of these makes a difference. So when you place it, it's an angulation of one ring over the other. So the good quality definitely makes a difference, and we have been using since last 4 years, so definitely there is no sagging over the years, sir. Thank you, sir.
Next speaker, Dr. Kshitija Pathak.
Good morning, everyone. My topic for today is enhancing outcome prediction in malignant otitis externa and innovative symptom-based prognostication. So as all we know, it is an aggressive invasive form of skin inflammation, also called as necrotizing otitis externa or skull-base osteomyelitis. The infection spreads deep to the temporal cortical bone and skull base. So most commonly it is seen in type 2 diabetes mellitus and elderly patients. Most common pathogen being Pseudomonas followed by all other. The clinical findings being severe otalgia, otorrhea, hearing loss, granulation and polyps. Facial is the most commonly affected nerve, and the treatment till now it is long-term antimicrobial therapy. Role of surgery is little controversial. So these are the classifications which were based coming to the scans and MRI based. Levenson's criteria was also put up for the diagnosing malignant otitis externa. We all know about these classifications. These are the traditional approaches. Objective of my study, it is an innovative and non-traditional clinical approach, and the key factors that influence the prognosis, I am just putting it up. So material and methods, it is a retrospective descriptive study from January 20 to December 24. 16 patients were included from the age 18 to 88 years. All the detailed documentation of symptomatology was done. Other things such as microbiological, pathological, and radiological imaging was used as an adjunct tools. So symptomatology, these were the symptomatology for number of patients. Total patients are 16. Most common was seen as otalgia, followed by discharge, edema, polyp, and so on. So the classification what I am coming with, it's based on only symptomatology and comorbidity. I have categorized these 16 patients into category A. Category A says that the adults with only complaints of severe otalgia and or itching in the ear, with or without headache, and with or without otorrhea, with no comorbidities. Category B patients, these are the adults with complaints of otalgia, otorrhea, polyps, granulation in the external auditory canal with diabetes mellitus. Category C patients, all the above complaints along with the cranial nerve palsies. And category D patients, all the above complaints, and those are the immunocompromised patients. So coming to category A, these were the patients who presented to us. This is the picturization. They only had the history of ear trauma, earbud use, along with the severe nocturnal otalgia, itching, headache, and otorrhea. No other comorbidity. These are the documentation for the 4 cases. The first 2 cases had intact normal tympanic membrane. The ESR was raised in all the cases. Blood glucose and HbA1c, it was slightly higher in one of the cases. Pseudomonas was isolated as the 3rd patient had history of ear discharge also. As I told, there was a positive history of repeated ear cleaning. Other evaluation for the severe headache was done, such as eye examination, cranial nerve, and the detailed history of migraine, tension, headache, stress was also ruled out. But there was no specific cause which was found out, and they were also subjected to MRI, and it showed early infections of skull base. The detail of this condition was explained, and the case was again treated, such as painkillers and oral antibiotics initially. They did not improve, and then therefore they were hospitalized. IV antibiotics were given. Some of the patients did not wanted to stay in the hospital, so they were shifted on oral antibiotics and discharged. Coming to category B, these are the diabetic patients. 8 patients were included, and they were coming with the complaints of ear discharge, headache, tinnitus, hearing loss, fever, and ear fullness. This is the clinical presentation. Third picture shows the granulation tissue and the polyp in the ear. Coming to the symptomatology, all were diabetics, 3 were uncontrolled diabetic. Most common symptomatology which is seen is otalgia, seen in all the patients, followed by ear discharge. Coming to investigations, ESR was raised in all the patients. WBC was increased in 4 of the cases. HbA1c was increased in 3 uncontrolled diabetic patients. Blood glucose was higher side, most common being the pseudomonas, which was isolated, followed by aspergillus. 2 cases had lost to follow-up, they were not willing for admission. The other cases were treated with oral toileting, antibiotic drops, and oral antibiotics initially. After that, they were hospitalized. IV antibiotics was given for the duration which is mentioned in the chart. Category C patients, they came with all the symptoms such as otalgia, headaches, facial weakness, ear fullness, and discharge. They had cranial nerve palsy. 2 of my patients had this facial palsy. The HRCT was done, which initially it was showing a picture suggestive of otomastoiditis, which was a little confusing picture for getting it diagnosed as a skull-base osteomyelitis. Symptomatology, they were diabetic, severe otalgia, again with discharge, polyp, and edema. Investigations, initially it was treated as a facial palsy secondary to COM patients, but there was no improvement with respect to the discharge and symptoms after antibiotic course. Severe persistent headache was seen, and they were subjected to MRI. It was showing features of osteitis. So they were treated accordingly. Steroids were also given, hospitalized for the IV antibiotics. Oral antibiotics were also given after the discharge. They were advised surgery for the discharge and COM, but they had refused for that. Category D patients, the first case, in addition to all the above symptoms, they had severe TM joint pain and facial pain. Second case has undergone radiation therapy 15 years prior, as he was diagnosed as nasopharyngeal carcinoma, asymptomatic for the 14 years, and again he presented with discharging ear and severe headache. So these are the 2 cases categorized into category D. The second case also got COVID infection followed by mucormycosis and was admitted in hospital. He also developed acquired infection, also had dysphagia and slight altered consciousness. The first patient, he also had severe TMJ the TMJ pain. So this was the CT scan which was done. It shows very severe. This is the TM joint in the left side. Also the ear was getting involved. So the picture for the investigation, ESR and CRP was raised in these patients. WFC, lymphopenia and platelets were also decreased. The second patient had also candida infection. So they were treated accordingly. Coming to results, males were most common in my study, followed by females. Most common symptom had been severe otalgia, followed by discharge, edema, polyp and headache. The mean age of patients according to these categories are 57, 62, 60 and 70 respectively. They were hospitalized for so many duration. The control and symptom free period was achieved after so many days, and the prognosis, as the less number of admission days, the prognosis was good. As they were kept more in the hospital, the prognosis was becoming severe and bad. So coming to results, as I told, severe otalgia was most common symptom. Prognosis was predicted only on symptomatology. Yeah.
A very difficult topic to talk, I know.
So I have a lot of data. It's very difficult to concise in 8 minutes.
I can understand. What were the most of the cases you had was Pseudomonas.
Correct.
So what was the course of duration of, you said severe cases were 20 days you said.
Correct, sir.
Of IV antibiotics. What are your preferred
initially, those who did not have discharge, they were very difficult to diagnose. They were not ready to stay in the hospital also. For them, we had shifted to the oral antibiotic. Those who had discharge, it was little easier to convince, and those were hospitalized for the IV antibiotics.
What was your preferred IV antibiotic?
IV antibiotic initially piperacillin and tazobactam was given, but like accordingly we had seen the improvement for the patients. If they were not, also the discharge was collected and sent for the culture sensitivity, and then accordingly we had treated. Also meropenem was also considered for these patients.
Respected judges, only one question please. We are running very late.
Thank you, sir.
May I call the next speaker, Dr. Prasun Mishra, sir?
Good morning to all of you. My presentation today is learning curve in airway surgery and our experience of 48 cases which we have treated over last 3 years. So in spite of ENT surgeons, all of us who are doing multiple number of cases, not many go into the field of airway surgeries. And very understandable that airway surgeries demand not only technical expertise, it requires a lot of understanding of health economics. Till the time patient reaches a ENT surgeon, he has shelled away all his money in ICUs, and then when he reaches the ENT surgeon, there is hardly much we can do with the limited money that he has. And the learning curve in airway surgery reflects the time and experience for a surgeon to achieve proficiency in the complex and with the high stakes fields. It has got procedural complexities. The patient variability, every patient will behave differently. We will think that I have done a perfect job, but the patient will not respond in the way that we want, that we have expected. And technology changes. It started with laser, coablator, debriders, balloon, stents, mitomycin. Technology keeps changing and everyone comes with their own paper saying that this affects, this results well, this results well. So where should we go and how do we learn out of it? So the aim of this surgery was to, in our airway surgery center, which we have started 3 years back, to explore the critical factors influencing the learning curve of an ENT surgeon, the challenges faced and the strategies to optimize a learning process. We also have our experience of 48 cases which we have treated. So we started clueless. We had a center, let us start the center, and I read books, attended conferences, understood the basic concepts of airway surgeries. And once I understood conference, we saw some YouTube videos, I realized I am expert, I can do the surgeries. So I started my cases. I started doing laryngomalacia cases. I did 3 cases. A case of subglottic stenosis with grade 2 and subglottic with grade 4. The results were obviously not very accepting. The laryngomalacia child did not improve. When I used a bougie dilatation, I realized that I had created more problem to the patient rather than giving him any help. And only the third case, from grade 4, he became grade 3. I don't know, it is a matter to be happy or not to be happy. So I realized that though I became naively confident, it was not the right direction in which I was moving in to understand or to go into the field of airway surgeries. So we came to a discouraging reality to know that no, there is something much more which needs to be understand this topic. So we needed more experience. We needed some mentorship. We needed mentors who have been in this field for long duration, and from them we need to learn this. More training, a definite support from center. If the center or the institute where you're working does not support you well for airway surgeries, it may not be a right place to work for. A team dynamics, I alone cannot do it. We require a team of ICU physicians, the staff nurse, our students, the staff, everyone. A team dynamics is very important, and every case is our teacher. We learn with I can see some airway surgeons here, and every case is our teacher. So very few important points which I have realized in this learning curve was health economics is one of the most important point in airway surgeries. Pediatric airway is not just a smaller form of adult airway, and T-tube can't be used everywhere, and same is lasers. T-tube lasers cannot be used everywhere, and airway is more robust than I think, because many times we feel that patient is in stridor, he requires tracheostomy, but we do some conservative management and these patients definitely pull on for longer duration. So it is much more robust than we think how it is. And alone we definitely cannot, we need a mentor and we need teamwork. So over last 3 years, we did 48 number of cases, and the study says, and we had the majority of cases were of subglottic stenosis, almost 22 patients were subglottic stenosis. We had 12 of tracheal stenosis, which include the cervical and thoracic trachea as well. We had cases of bilateral vocal cord palsy, 4, laryngomalacia, 5, and 2 cases of vallicular cyst, a case of laryngeal edema post-trauma, and 2 bilateral choanal atresia. So this was my variety of cases which we have treated over last 3 years. It was a range of pediatric and adult, almost equal distributions, because we have a good pediatric center at our city, and so we do get a lot of pediatric cases, so almost equal distribution of pediatric and the adult cases. The results. Laryngomalacia cases, we had 5 cases, of which in 2 of them we did A-fold resection. Initially it was thought that lasers are the thing, but remember, lasers, coablators, cautery is not supposed to be used. That is what the recent trend is. We have to use either scissors or cutting instrument, tissue cutting scissors or debriders. So in 3 cases we used area epileptic fold resection along with the mucosal debridement of the mucosa on the bulky arytenoids. None of the patients were on tracheostomy. Most of the children did well immediately in 3 to 4 days period. One child is not recovering as per our expectations. Subglottic stenosis. Of the 22 cases that we had, 9 we did excision of the stenosis and putting by the Shanley technique and putting the T-tube at those sites. The T-tube was kept for 6 months and then removed. And 7 of these patients went off tracheostomies. 2 are still on tracheostomies. 5 patients, depending on the grade, we went for balloon dilatations. 1 is still patient on tracheostomy. 5 we did the LTR and stenting of that part, and almost all of them are off tracheostomy, and 3 of them we did trichotracheal resection. Unfortunately, one of these patients passed away. We lost one of the child. But the idea is that we had a large chunk of subglottic stenosis from complete stenosis to grade 2 or grade 3 stenosis, and considering the success rate of 68%, we think we are doing reasonably good in management of subglottic stenosis, and success we are defining in the form of patient being out of tracheostomy. Tracheal stenosis, we had 12 cases, of which 8 of them are now off tracheostomies, 9 were cervical, 3 of thoracic. For thoracic tracheal stenosis, T-tubes work the best. That is what we have realized. And in the cervical part, we can use balloon dilatation, a CTR, or we can use a stent or resection along with T-tube. And 7 are off tracheostomies, and 2 patients are still on tracheostomies, a humble success rate of 66%. Besides the other miscellaneous cases, we had 2 cases of bilateral choanal atresia. Both are now doing very good without any problems. 4 vocal cord palsies we have done with coablation. The chordotomy was done, and we got reasonably good space. Some voice compromise was there, but over a period of time, patient learned to use that voice. Vallicular cyst patient removed marsupialization with coablation, doing good, and 1 case of recurrent laryngeal papilloma. All of them are doing good, none of them on tracheostomy. So we did have our share of failures. 7 patients are still on tracheostomy, and we are struggling to decannulate. We are trying to find out the exact reason. We try to treat the cause, but the stenosis somehow comes back at its place. One patient unfortunately passed away, one patient developed tracheocutaneous fistula, 8 are now grade 1 stenosis. We are keeping our fingers crossed that they will not progress to grade 2, and we are keeping them on follow-up. However, a modest success rate of 67% endoscopically, when obviously grade is less, so the success rates are higher. Where we have used balloon and open, we have a success rate of 63%. Literature says there are multiple, obviously it's a study which requires a lot of research, and there are multiple publications already there. They claim LTRs to have 90 to 95% success rate. We are still far away from this. Obviously by balloon method or the earlier grades, we have a good success rate, but until and unless we have good success rate for grade 3 and grade 4 stenosis, we cannot say that we are doing excellent in this field. So, learning curves, we have achieved quite a bit, but still a long way to go till we reach masterly achieved. Right now, I think we would be somewhere in the area of reaching the plateau from the discouraging realistic state, but I realize that this is a good field to grow. And to conclude, airway surgeries have a steep learning curve. At our center, we have had good success rate. However, I understand that smiling face of a decannulated patient will motivate us to work more and more. Thank you so much for your attention.
Actually, what do you personally find
Yes.
has been best in your hands for, say, grade 2 stenosis?
So, grade 2 subglottic stenosis, generally nowadays balloon is being preferred, ma'am. So, if it is grade 2, we just dilate the area with balloon, put some Kenocort on that area, and we keep the patient. After 1 month, we again do a scopy in the OPD to check how much dilatation is there. Most of times, by 1 or 2 dilatations, grade 2 stenosis, they work the best, ma'am, with balloon dilatation.
With balloon dilatation?
Yes, ma'am.
Okay.
Even in grade 3, giving a cut incision with coablator and then ballooning works good in most of the cases.
But they require follow-up?
Yes, ma'am. All every cases we keep on follow-up till the time for at least 2 years till we are sure that there is no more stenosis coming up.
And are they agreeable? They come regularly?
They come, ma'am, because frankly not many centers, they will take them on follow-up because they don't have money. So they come to our center and then we try to provide them with some economic help also.
Okay.
Thank you so much.
May I call upon next speaker, Dr. Vasanti Patil?
Good morning everyone, I am Dr. Vasanti Patil. Today's topic of presentation is right non-recurrent laryngeal nerve, a case report. So inferior laryngeal nerve is commonly referred to as a recurrent laryngeal nerve. It is a branch of cervical vagus. Right inferior laryngeal nerve follows non-recurrent course in 0.7% population. It was first reported by Stedman in 1823. It gives both sensory and motor supply to the larynx. Risk of injury to the recurrent laryngeal nerve is 1 to 2% during routine thyroid surgery. But when it comes to non-recurrent laryngeal nerve, it comes to 12 to 12.9%. It is first reported by Pemberton in 1932. Damage to recurrent laryngeal nerve during thyroidectomy is responsible for permanent vocal cord paralysis. The aim of this case report is to know the prevalence and its rarity to prevent accidental damage. My patient is 36-year-old lady from Isalkaranji. She came with chief complaints of midline neck swelling since last 20 years, dysphagia since last 6 months. There was no history of difficulty in breathing, noisy respiration, no history of change in voice, no comorbidities, no addictions, but history of tonsillectomy 28 years back. On clinical examination, single midline neck swelling of size 10 by 6 by 5 centimeter. It extending from right sternocleidomastoid to the left sternocleidomastoid skin, and temperature of the swelling was normal. It was firm on palpation. It was moving upwards during deglutition, and I was able to get below the swelling. There were no lymph nodes, and video laryngoscopy was absolutely normal. All the investigations were normal. Thyroid function tests were normal. On USG, multinodular hyperplasia of the thyroid. On FNAC, it is a colloid goiter, Bethesda category 2. So, plan was total thyroidectomy. So, routine Kocher's incision has been taken. Routine skin platysma was incised. Upper and inferior flaps are elevated. Strap muscles are retracted. Then, this right lobe of the thyroid is delivered from the paratracheal gutter. Then I found inferior thyroid artery. I tried to find a right recurrent laryngeal nerve in the routine tracheoesophageal groove, but I was not able to find. So I found white glistening structure. Here you can see the white glistening structure So it was running above the inferior thyroid artery, parallel to it, and it was going upwards. So I traced it upwards. It was arising directly from the vagus. So it was a right non-recurrent laryngeal nerve. So here in this figure, A is right non-recurrent laryngeal nerve, B is vagus, C is common carotid artery, and D is retracted thyroid gland. On the left side, recurrent laryngeal nerve was routine. It was in the tracheoesophageal group. This is excised specimen of the total thyroidectomy. So it was measuring 13 by 10 centimeter. On histopathological examination, colloid goiter with nodular hyperplasia with lymphocytic thyroiditis. So post-operatively, as I found the right non-recurrent laryngeal nerve, I have done CCT neck with chest of this patient, and I have found the right aberrant subclavian artery. So here in first axial cut, you can see it is going behind the esophagus, and here also it is crossing the midline and going on the right side. It is arising distal to the left subclavian artery. So non-recurrent laryngeal nerve, it is a rare and it results from the partial failure of pharyngeal fourth pouch during embryonic development. And non-recurrent laryngeal nerve easily be injured surgically, and this will lead to the permanent vocal cord palsy. Adequate identification and isolation is very important to prevent injury. Prevalence of the right non-recurrent laryngeal nerve was strongly associated with the presence of aberrant right subclavian artery, which will lead to the dysphagia lusoria. Existence of non-recurrent laryngeal nerve without the associated vascular anomalies has no clear embryological explanation. Non-recurrent laryngeal nerve on the left side reported only few times, 0.004%, and it is always associated with situs inversus and right-sided arch of aorta. The non-recurrent laryngeal nerve risk increases, six-fold risk will be there during surgery. So in this first figure, you can see the normal course of right recurrent laryngeal nerve, and in the second figure, you can see the non-recurrent laryngeal nerve. There are types of non-recurrent laryngeal nerve. In A figure, you can see it is arising above the level of the laryngotracheal junction, and in figure B, you can see it is arising below the level of the LT junction. According to AVC classification in the second figure, the type 1 is when it follows the course along the superior pedicle vessels. Type 2A is it is parallel or along the inferior thyroid artery, but it is above the level of the inferior thyroid artery, and in 2B it is below the level of the inferior thyroid artery, courses transversely or in between the branches of inferior thyroid artery. So according to the Bradman-Henry meta-analysis studies, they studied almost 33,571 cases of right recurrent laryngeal nerve. So they found 0.7% pooled prevalence, and 58.3% cases were arising above the level of the LT junction, and 41.7% cases were arising below the level of LT junction. 86.7% of the cases of right non-recurrent laryngeal nerve had an aberrant subclavian artery pattern. Use of intraoperative nerve monitoring will increase prevalence of non-recurrent laryngeal nerve, but it will reduce the post-operative nerve palsy and the morbidity. Steadman was the first person to see the non-recurrent laryngeal nerve in the cadaver in 1823. This is the beautiful photos of Steadman on the cadaveric photos you can see in this slide. So according to the Immaul Bacalins et al. Studies, in their 104 non-recurrent laryngeal cases, they have found 97% cases were associated with aberrant right subclavian artery, and one case was there which was intrathyroid right common carotid artery in 23-year-old patient. It is a rare anatomic variant with incidence of 0.3 to 0.8% in this study, and 0 on the right side and 0.004% on the left side, and female preponderance was found with a ratio of 2:1. Here in this first picture you can see the normal course of recurrent laryngeal nerve on the both sides. In second picture you can see this is non-recurrent right-sided non-recurrent laryngeal nerve, and the third picture you can see the intrathyroid common carotid artery, and last picture it is a left-sided non-recurrent laryngeal nerve with situs invertus. So to conclude, non-recurrent laryngeal nerve increases risk of iatrogenic nerve injury, either temporary or the permanent vocal cord paralysis. Complete understanding of the prevalence, origin and associated pathologies is very vital to prevent injuries and for ensuring patient safety. Solid anatomical knowledge and methodological dissection with meticulous dissection to locate recurrent laryngeal nerve minimizes morbidity. Thorough preoperative USG scanning is very important to know the vascular anomalies, and accordingly we can predict that there might be non-recurrent laryngeal nerve. And in needed cases, you can do contrast enhanced CT scan and intraoperative nerve monitoring, which will minimize the risk of injury to this nerve. So here is my happy patient, you can see. Thank you.
A very nice presentation.
Thank you, sir.
And it's really difficult to face such situation on the table.
Yes, sir.
So I think you've handled it very well.
Yes, sir. Thank you so much.
I agree, the presentation was good, but I'm trying to really think that, did it help you? Do you feel in future now you would look for it?
Yeah, definitely, ma'am. Because whenever I will try to operate on in a thyroidectomy, hemi or total thyroidectomy, I will suggest radiologists to do thorough USG examination. Because ECT or intraoperative nerve monitoring will not be possible in every case. If we do proper USG with probe directing towards the upper inlet of the thorax, we can definitely diagnose vascular anomalies prior to the surgery, so that we can predict non-recurrent laryngeal nerve.
So what message would you like to give?
The thorough USG scanning and reading and talking to the radiologist pre-operatively is very important.
Okay, thank you.
Yes, ma'am. Thank you.
Our next speaker, Dr. Tanishka Bakshi.
Good morning, everyone, respected judges and all my seniors. My topic is Skeeter-assisted stapedotomy, a reliable technique, a study of 500 cases. So otosclerosis is a localized hereditary disorder of the otic capsule characterized by disordered resorption and deposition of bone. Bone desorption, as we know, is by the osteoclast, and new bone formation is by the osteoblast, accompanied by vascular proliferation. Progressive conductive hearing loss is usually the complaint that patients come with. It is more prominent in females than in males. Stapedotomy is a gold standard procedure for treatment of otosclerosis. Small fenestra stapedotomy is associated with less risk of complications. Various methods for making fenestra, as we know, are perforator. There are different sizes of perforator, 0.4, 0.6 and 0.8 mm. CO2 laser with 0.4 mm spot size, argon laser, skeeter drill and micro drill. Perforator needs a controlled hand. Exposure while making the fenestra is sometimes very difficult. Difficulty in making fenestra in obliterative otosclerosis and narrow niche with a perforator. And sometimes the blunt perforators can cause a cracked foot plate or destabilize the foot plate due to application of more pressure. Lasers are costly, difficult to maintain, difficult to make fenestra in overhanging facial nerve and in obliterative otosclerosis. And there is also a chance of injury to the dehiscent facial nerve. Microdrill has a bulky handpiece and can compromise the exposure by coming in the way. Low speed drilling is not possible with present technology. So advantages of skeeter in small fenestra stapedotomy are, it is cheaper as compared to laser, lightweight handpiece gives better precision and less pressure on the foot plate, angled shaft gives better visualization during drilling, controlled RPM up to 1000, reduces acoustic trauma to the vestibule, foot plate with uneven ridges and thickness can be drilled evenly in a controlled manner. In obliterative otosclerosis, this is the only tool which gives better results. In difficult anatomy like narrow niche, it can be tackled by drilling the promontory with skeeter. Thick posterior crust can be dealt safely without causing floating foot plate. Our data, we have 500 cases of stapedotomy with skeeter over a period of 10 years. The AB clap closure was less than 10 decibels in 95% of cases, and 10 to 20 decibel in 3.5 and more than 20 decibel in 1.5% cases. So the routine steps of the procedure are taking an endoral incision, raising the tympanomeatal flap, drilling the overhang and curating to expose the foot plate. So drilling the foot plate with the skeeter, it is just a very good exposure, measuring the distance, measuring the length of the piston, making the fenestra, and finally placing the piston. So drilling the edge of the fenestra is also possible sometimes when we need to adjust the circumference of the fenestra. So this is very much possible with a skeeter, and it helps us achieve the exact size of the fenestra which we have in mind. So in a narrow oval window niche with overhanging facial nerve, we see that it is the only technique which helped us gain a good exposure and place the piston. So this is a video of it. So this is, as we can see, is a very, very narrow oval window niche, and we start with drilling. The exposure just keeps on getting better. We also see that the skeeter doesn't come in our way, and it is easy to assess intraoperatively. The facial nerve lying just next to the oval window, it is untouched, and we can successfully make a fenestra and place the piston. In obliterative otosclerosis, as we can see, the biscuit foot plate, it is very easy to surface drill the foot plate and cause blue lining of the foot plate, and then we can use either the skeeter to make the fenestra or the perforator. It is the surgeon's choice, but as we do it completely with the skeeter, we go ahead with making the fenestra with the skeeter after blue lining the foot plate. So sometimes there is a very irregular foot plate with some ridges on the foot plate. So before placing the piston, we want to make sure that the foot plate is evened out. So skeeter also makes it very easy in these cases to just drill the edge of the foot plate and the margin, irregular margins, as we can see in this case. So, concluding, I would like to say that skeeter-assisted stapedotomy is a reliable technique for drilling foot plate. It addresses all situations like thick posterior crust, thin foot plate, ridges and irregular foot plate, narrow oval window niche, overhanging facial nerve, obliterative otosclerosis. Thank you.
Would you advise people to use skeeter? When would you use a skeeter? How would you realize?
Ma'am,
How would you decide?
Ma'am, I would definitely advise everyone to use skeeter, and as I showed in all the difficult cases and even in the routine cases, skeeter is a better option as it provides a very controlled drilling. Chances of injury to the foot plate and the facial nerve are minimal using a skeeter, and even in difficult situations, it just comes handy.
So you feel it's a safer tool to use?
Yes, ma'am.
Oh, thank you.
Thank you.
Our next speaker is Dr. Shahrukh.
Good morning, one and all, respected judges and chairperson. Myself, Dr. Shahrukh, and the title of my presentation is Combating Persistent Otorrhea by Treatment Based on Antibiogram Patterns, a tertiary hospital-based prospective study. So as we all know, the chronic otitis media, it poses a very huge challenge to all the otologists globally because of its unpredictable course. Though the pathogenesis of this disease is studied in detail, but due to varied microbial threats, this continues to be a quarrelsome issue among all the otologists worldwide. And now we are facing the biggest threat of having antimicrobial resistance. So in such scenarios, assessment of ear discharge for bacteriological profile and antibiogram patterns gives prompt results. So coming to the aims and objectives, the aim was to document the antibiogram patterns in chronic otitis media and establishing a clinico-microbiological correlation to achieve a dry ear. And the objectives were to analyze the antibiogram for the most common organism involved, its susceptibility and resistance, and to determine the most commonly used antimicrobial agents, and the most important, to assess the effectiveness of these antimicrobial agents in achieving dry ear. So coming to materials and methods, we had studied 228 isolates of patients with chronic otitis media over a period of 1 year, and all patients who presented with persistent ear discharge for more than 3 months who satisfied our inclusion and exclusion criteria were taken up for the study. So the inclusion criteria included all the patients who were in the age group between 10 to 65 years who had persistent otorrhea for more than 3 months and prior failed tympanoplasty with ear discharge. However, the cases with history of road traffic accidents, otitis externa, prior systemic or topical antimicrobial or antifungal treatment, and neoplastic and skin diseases were excluded from the study. We had taken dual consent, that is written and oral, from all the participants prior to the participation, and on the first visit of their OPD visit, we had taken ear swabs. Then all the samples were subjected to gram stain, Ziehl-Neelsen stain, and KOH mount. And for culture, blood agar, McConkey agar, and nutrient agar was used. And to report the antimicrobial susceptibility, Muller-Hinton agar was used, and antibiotics were impregnated using CLSI guidelines of 2024. And all these patients were called 3 days after with the culture and sensitivity report. So based on the report, all patients received either an oral or intravenous course of antibiotics, and all participants were called once in consecutive 3 weeks to see for any persistence of discharge or whether the ear was free following the treatment. So coming to the results, the maximum pool of patients what we observed in our study belonged to the age group of 16 to 25, which accounted for 24.12%, and least were in the age group of 56 to 65. Coming to the demographic data, we observed that female predominance was seen in our study, and majority of these patients were housewives and students. And the comorbidities which we addressed in our study were diabetes mellitus, allergic rhinitis, and hypertensive. And 23 patients had previous history of surgery. And on otological examination, we observed mucopurulent discharge in majority of cases and central perforation, which was the commonest one. And patients, as a routine, they gave the history of ear pain, ringing sensation, giddiness, and reduced hearing. So we tried to correlate the causative organism with the duration of ear discharge. So we found that the most commonly encountered organisms like Pseudomonas and Staph aureus, we expected the maximum duration in them. But to our contrary, Enterococcus and sterile group had the maximum duration of ear discharge prior to the treatment. And then we tried to correlate the type of the infective organism and the characteristics of ear discharge. So in this group, Staphylococcus aureus and E. coli had mucoid type of discharge in predominant cases, and whereas all remaining cases, be it fungal or bacterial causes, they had mucopurulent. But in sterile cases, we had purulent variety of ear discharge in majority of the cases. Then, after reporting the culture and sensitivity, we tried to see the number and percentage of sensitive strains. So for Pseudomonas aeruginosa, piperacillin was the most promising agent, followed by amikacin and ciprofloxacin. For Staphylococcus aureus, it was doxycycline, clindamycin, and linezolid. For Klebsiella pneumonia, the agent was cefotaxime and gentamicin. As for Acinetobacter, piperacillin and gentamicin. E. coli showed susceptibility to gentamicin, followed by cotrimoxazole. Enterococcus for doxycycline, and we had single cases each of Proteus and Streptococcus. So following treatment and on consecutive visits, we tried to maintain a record of all the patients who had achieved dry ear. So for Pseudomonas, the best results were with ciprofloxacin. For Staph aureus, it was with doxycycline. For Klebsiella pneumonia, it was with cefotaxime. And for Acinetobacter, it was with piperacillin. So the characteristics of ear discharge were correlated with the comorbid condition, and diabetic patients had more mucopurulent type of ear discharge, hypertensive with purulent, and allergic rhinitis with mucopurulent type of discharge. And on consecutive visits, we tried to assess assess for the ear discharge, but even after the attempts, we managed to get 83.33% of the cases. That is 190 cases out of 228. So there was a correlation between the infective, means on the day 21, we tried to see what was the main causative organism for having persistent ear discharge and what were the comorbid conditions associated with it. So the Pseudomonas group had maximum of allergic rhinitis patients and sterile group had majority of hypertensive patients. Coming to discussion, as we all know, this is a global issue, and similar to our study, Zhang et al. Showed female predominance, and maximum pool of patients were between 16 to 25 age of year group, which was similar to Pavni et al., which is an Indian study done in Chhattisgarh. Then diabetes and allergic rhinitis were the main common comorbid conditions, similar to Van Diemen, and duration was less in our study as compared to other studies who reported 60 months. And we observed non-foul smelling, profuse mucopurulent type of ear discharge, which was similar to an Indian study, and we saw majority of the central perforations. In our study, the culture was yielded positive in 85.96% cases, and we saw monomicrobial bacterial isolates more. Pseudomonas was sensitive to piperacillin, amikacin, and ciprofloxacin, which was contrary to the study done in Belgavi. And methicillin sensitive and methicillin resistance was sensitive to clindamycin linezolid. All these findings were similar to Sharma et al. Klebsiella results were in contrast to a study done in Kingdom of Saudi Arabia. And Vikash Prakash highlighted the issue of using gentamicin in the treatment because of ototoxicity. And a study in Aldivania showed that the sensitive agents for E. coli were amikacin, ciprofloxacin. And we observed 32 sterile cases. So what were the causes of these sterile cases were anaerobic growth, biofilm production, and non-bacterial causes. To conclude, the chronic otorrhea poses a huge challenge to all the otologists worldwide, and patients' poor compliance, multiple treatments, prolonged antimicrobial ear drops, poor hygiene, and inadvertent usage of higher antibiotics develops this antibiotic resistance. Hence, culture helps to aid and give proper medical management to achieve dry ear. Thank you.
What message would you like to give that if you see a patient in the OPD, would you do a culture in every case before you start in chronic otorrhea?
Yes, ma'am, I would suggest that since it is becoming an issue, like we are not able to give a dry ear to the patient, which is the most quarrelsome issue for the patient. And depending upon the history, he has taken multiple treatments, and we have multiple setups from where the patients are referred to. So better to take a culture rather than giving an empirical treatment, because that we have some evidence, and plus we can help in further studies to quote whether the particular antibiotic is susceptible or not.
But in your study, did you see the nature of the discharge?
Yes, ma'am.
Does that help you to identify the type of organism?
Ma'am, in the start, we were compiling the data, but as and when, after around 6 months, we were able to find out what might be the characteristics. But certain cases, we were confused, though we thought that there might be some bacterial cause or fungal cause, but the cultures were turned to be sterile. So that sterile is one of the lacuna which is not at all studied anywhere in the things, ma'am.
Right. Okay.
Thank you.
Next speaker is Professor Sambhaji Chintale.
Good morning to all the respected chairpersons, judges, and the teachers and delegates. My topic of presentation is experience of clinico-pathological study of thyroid swellings. As we know, the thyroid gland is unique among the endocrine gland in that is the first endocrine gland to appear in the fetus. It is the largest endocrine gland, weighing about 25 grams. Disease of thyroid glands are extremely common. Palpable thyroid nodule of the majority are asymptomatic, occurs in 5% of the population. Prevalence rate is considerably lower but significant because of chances of malignancy. Aims and objective of the studies. The main objective of present study is to know the accuracy of FNAC in a preoperative diagnostic of clinically palpable thyroid swelling, to evaluate the efficiency of fine needle aspiration cytology, USG, thyroid function test, to differentiate between benign and malignant thyroid swelling and their confirmation by histopathological report after the surgery. Method, this is the prospective studies conducted during the 2016 to 2019. For the purpose of inclusion in this study, we inclusion criteria all the patients present with thyroid swelling to the ENT department, patient referred from other department to the ENT department. Exclusion criteria, those patients who are not giving consent and not willing for surgery, and those patients having the pubertal goiter. All the routine investigations done, detailed clinical history is recorded. The results, the sonographically, the nodule were evaluated for the size, location, ecotexture, margins, presence of halo, calcification, accessory nodules, associated cervical lymphadenopathy, and consistency to differentiate between the benign and the malignant. Patient with the deranged TFT were treated medically, and those patients underwent surgery and histopathological examination of specimen was obtained. Finally, the histopathological were considered with finding of FNAC in order to evaluate their sensitivity and specificity by the statistical methods. Swelling is between the second to fourth decade. Youngest patient is of 20 years and oldest is 68 years. According to the age groups, we divided into the 10 to 20 years, 21 to 30s. This was total 110 cases. Clinical symptoms like thyroid swelling, pain, dysphagia, change in voice. Common is the swelling is present in the neck. Then in malignancy cases, there may be all those palpitations, changes in voice, dysphagia, and overall the hypothyroidism patients may guess with the signs of the intolerance, cold intolerance, menstrual irregularities. The duration of the swelling less than 6 months in the 20 cases, 6 months to 1 year is 35 cases. 1 year to 2 years, 25 cases, 2 years to 3 years, 30 cases, more than 5 years, 10 cases. According to the consistency, the soft, firm and hard, and with malignancy, there is an involvement of the cervical lymph nodes in a few cases. According to thyroid swellings that we have divided, there is solitary nodules, multinodular goiter, diffuse thyroid, thyroid cyst, carcinoma, and thyroiditis. These are all different types of benign lesions that are involved in the studies along with malignancies. On FNAC reports, these are colloidal goiters in 48 cases, thyroiditis 8 cases, thyroid cyst 30 cases, benign thyroid lesions including that. In carcinoma, we have only the papillary and follicular carcinoma 1 case and papillary in 5 cases. Inclusive reports on the FNACs in 9 cases. The colloidal goiters, histopathological reports, colloidal goiters is in percentage 38.33%, thyroid cyst in 18%, adenoma 15%, multinodular goiter 9.16%, thyroiditis 5.830%, and papillary carcinoma 4%, follicular 1%. In routine use of FNAC in evaluation of thyroid nodule can reduce the need for the diagnostic thyroidectomy by 20 to 50% while increasing the yield of cancer diagnosis in the thyroid nodule. Our histopathological findings, present studies compared to the previous studies, that is Ramkrishna and Nagoretals. Colloidal goiter is found in our studies 38% and Ramkrishna in the 36.3%. Thyroid cyst in 18.33% to Ramkrishna 2.3%. Thyroid adenoma 15%, 53%. And Nagoretal 44%. The previously studies have showed the report in consistently with our studies. Then histopathological number for malignancies, the papillary carcinoma in our studies is 5 cases, FNAC diagnosed in the 5 cases, total number 5. Follicular carcinoma is 2 cases, the FNAC could not find out it, but histopathological confirmation 2 cases. The diagnostic accuracy for the cytology is that the overall diagnostic accuracy for FNAC is 99.15%. The comparison of diagnostic sensitivity and specificity of FNAC in a different series is that the Alta Weiler et al. In 1990, the diagnostic sensitivity of FNAC is 71%, 43%. Diagnostic specificity of FNAC is 100% in the most of the cases, that is Borvet et al., Janshonak et al., and present studies, or the diagnostic sensitivity is the 87.5% and specificity is 100%. The diagnostic accuracy of FNAC in the diagnostic accuracy is 99.15%. These are the few cases which we have included in our series of huge thyroidectomy, that is follicular carcinoma in the male patients. We have done the thyroidectomy with preservation of the recurrent laryngeal nerve as shown in this. This is the papillary carcinoma in the ladies with having his presentation with calcification in that. This is the how the calcified seen. This is the multinodular goiter having the classical presentation over the neck. This is the colloidal goiter. This is the colloidal cyst. This is thyroidal nodular goiter. This is the diffuse thyroiditis. This is the Hughes Hashimoto thyroiditis clinical presentations with the involvement of both the lobe along with isthmus enlargement. We have done few cases with using the microscope. This is a solitary thyroid nodule. The case of the thyroid isthmus, Hughes isthmus cyst with a black hemorrhagic collection within it. Few cases we have to plan with a properly with a few less bleeding or thyroidectomy. To achieve, we have to give proper infiltrations along the inferior and superior part of the thyroid glands. Thyroidectomy in burn patients is a very difficult to get the plane for in the burn neck patients. We have managed this type of cases also. This is a thyroid with the difficult intubation having the huge swelling from the submandibular region up to the retrosternal area, the deviations of trachea to the left. And this was the one of the huge case in our series of more than 700 cases till date, but the studies we have included 120 cases for the histopathological and FNC relations. In conclusion, FNC should be done in all the cases preoperatively. FNC is a safe procedure and cost effective. FNC is a high diagnostic accuracy, that is 99.15%, and help to differentiate it and between the benign and malignant lesions. So in every cases we have to do the all the T3, T4 investigation, FNC sonography. USG should be performed in all the cases of thyroid preoperatively to locate the mass, its extension, detect multi-nodularity difference between the solid, cystic, cervical lymphadenopathy and vascular involvement. Lastly, all resected thyroid tissue should be subject for histopathological evaluation. Thank you so much for attention.
Thank you, Sambhaji. As we have been told by the management now, we are really running short of time, so no more questions.
No issue. Thank you, sir.
Thank you all. Now I would request Chairperson Sir to felicitate participants. Dr. Sanika, Dr. Madhuri More, Dr. Neeleshkumar Pandit, Dr. Parab, Dr. Sapna, Dr. Tanishka, Dr. Prasun, Dr. Vasanti Patil, Professor Sambhaji, Dr. Shahrukh, Now I would request Chairperson Sir to felicitate the judges, Dr. Dhananjay Kulkarni, Dr. Pillu Hakim, Now I would request Dr. Tarangsha to felicitate Dr. Mashalkar.